So we are going to attempt to summarize many of the amazing abstracts that were presented at DDW this year that were related to colon and lower GI. A lot of these really are going to be focusing on colorectal cancer screening, really building off the wonderful presentation we just heard from Dr. Gupta. How did you advance? I see. Okay. Here are my disclosures. So as a quick overview, there are many topics that we're going to be discussing over the course of the next 40 minutes. We will be discussing abstracts that looked at the evidence for changing epidemiology of colorectal cancer, updates in colorectal cancer disparities, high-risk colorectal cancer groups, and artificial intelligence and colonoscopy. And then I'm going to pass the torch to Dr. Gupta, who will continue reviewing some more abstracts dealing with what's new in colorectal cancer screening tests, risk stratification for CRC, and CRC screening interventions. As we've just heard, there have been many changes in the epidemiology of colorectal cancer. And there were two abstracts at DDW that we wanted to highlight that really showed more evidence for the importance of these epidemiologic shifts. This first study was presented by Tim Zaki and Caitlin Murphy, and really looked at the birth cohort for early onset colorectal cancer globally. So as we know, we've seen shifts in this disease in the United States. 45 is the new 50, 50 is the new 55, but they really wanted to estimate the birth cohort effect of early onset colorectal cancer globally. Is this happening internationally? They conducted an age period cohort analysis. They included 7 regions of the world, and those are listed here on this slide. And they used data from the Global Health Data Exchange, which actually provides data on cancer and other chronic diseases in about 200 countries around the world. In their methodology, they created 5-year age groups and time periods to come up with 17 birth cohorts. And then they were able to estimate the rate of age-specific incidence rates for colorectal cancer in each birth cohort relative to the 1950-1954 birth cohort, which is the birth cohort where we started to see an increase in this disease in early and young individuals. They also reported incident rate ratios with 95% confidence interval. And I really love the figure that they were able to provide in this abstract because it really just visually demonstrates what we're seeing internationally with this disease. This is not a US phenomenon. We are seeing worldwide a birth cohort effect of colorectal cancer in young adults. They were able to show that colorectal cancer incidence increased in all region birth cohorts except Europe and Central Asia, right around 1950, 1954. And the incidence was up to 2 times higher for individuals who were born in the 1980s and 90s, really compared to this earlier birth cohort of 1950s. They really remark, I think in this study, what's really remarkable is that you see this similar shift in early onset cases, despite the region of the world that you're looking at. And we recognize that we have different age stratifications in these different parts of the world. People have different screening programs or different screening strategies in different parts of the world. Diet, lifestyle, other diagnostic availability and technology varies quite a bit, but we're still seeing this epidemiologic difference. The other main abstract that we wanted to focus on from DDW related to the shifting epidemiology of colorectal cancer was in the prevalence of adenomas and sessile serrated lesions in individuals who are considered to be in this young or early age cohort of individuals getting colorectal cancer. So we know that we have goals for ADR, or adenoma detection rate, for individuals who are 50 and older. And as we start to design our quality improvement programs in our institutions, the question becomes, do we have the same goals for individuals who are age 45 to 49? And that is what this abstract attempted to look at. They aim to report the prevalence of detected adenomas and sessile serrated lesions in 45 to 49-year-old individuals who are undergoing colonoscopy. What they did to answer this question is to perform a systematic review. They did a wide scope search of available peer review articles, and they identified studies that were reporting the prevalence of adenomas and SSLs in 45 to 49-year-olds who underwent colonoscopy really for any reason except for high-risk conditions. They were able then to generate a pooled prevalence rate with 95% confidence intervals and random effects. And they also looked at the heterogeneity of the study. We do this when we're looking at a systematic or meta review because we want to see how similar the studies are to each other when we make the comparisons and combine the data. What they found were 15 studies that met their inclusion criteria, and importantly, these studies were beyond the United States, so they were able to include studies from Asia, Canada, and France as well. When they looked at their pooled estimates of a prevalence of adenoma, there were 14 studies that they were able to include, and they found that the adenoma prevalence in this young adult population, 45 to 49, was 22%. The pooled ADR was about 27%. And in this last figure here, you see the data from the studies that looked at sessile serrated lesions. The pooled prevalence in these 6 studies was about 6 to 8%, 6%. And they were not able, just given the data that was available, to calculate a sessile serrated lesion detection rate. There was significant heterogeneity of these studies, which made it a little bit challenging to combine the data. But the overall conclusion from this abstract was that when we look at the prevalence of adenomas and sessile serrated lesions and adenoma detection rates in individuals who are 45 to 49, we actually can use similar goals to when we look at individuals who are age 50 to 54 or older. So when we're setting that goal of ADR of 25% in our health settings, we're probably doing okay using that goal as well as we extend the guideline to individuals who are 40 to 45, 45 to 49, which is important. Next, I'll focus on a few abstracts from DDW that provided updates in colorectal cancer disparities. As highlighted in the previous lecture, we do see differences in incidence and mortality in colorectal cancer by race and by ethnicity. And there were several abstracts at DDW that highlighted these differences over time and what we might do to eliminate some of these disparities. This first abstract that I'd like to represent looked at the impact of COVID-19 on whether or not providers in the United States were recommending colorectal cancer screening. We know that unfortunately during the pandemic, there were many health measures, including preventive health measures, that went underused. And there is much theory and actually not some data that particularly providers might not have been recommending preventive services during this time, given the heightened awareness about the COVID-19 and also getting patients vaccinated. In this study, they aim to explore the impact of the pandemic on screening recommendations. And they really also wanted to see if the COVID pandemic disproportionately impacted recommendations for specific groups. They performed a retrospective cross-sectional study using National Health Interview Survey data. They used data from 2 years, 2019 and 2021. And they looked at adults who were aged 50 to 75 who had never been screened for colorectal cancer before, performing a multivariable logistic regression to really identify factors that were associated with the likelihood that a provider is recommending screening for colorectal cancer. What they found was that during the time of the pandemic, there was about a 20% drop in referrals for colorectal cancer screening in 2021. That was an estimate of about 1.2 million fewer Americans that were recommended colorectal cancer screening in 2021 compared to 2019. They also noted that the lowest recommendation rates were in individuals who are uninsured, low income, and non-white. So this matches data that we had seen prior to the pandemic as well. And that disparities related to race and insurance coverage became more pronounced in 2021. The lowest recommendation group was actually our Hispanic or Latino population in the United States. The conclusion from this abstract was that a lower proportion of eligible individuals received a recommendation for colorectal cancer screening from a provider during the COVID-19 pandemic than prior to the pandemic. So really emphasizing the work that needs to be done to recovering from the pandemic. This next abstract that I will present also looked at COVID-19 recovery, particularly focusing on under-resourced populations, and which is important, as we've just learned from the previous abstract, that there are disparities in who's getting recommended for colorectal cancer screening. This study actually measured the change in colorectal cancer screening rates from 2020 to 2021 in community health clinics, which primarily take care of underserved populations. It was a cross-sectional analysis that looked at what we call the uniform data system. This is government data from HRSA that is mandatory reporting from the community health centers, and looked at a long period of time from 2014 to 2021. The goal was to look at the change in the screening rate from 2020 to 2021 in each health system, and also to determine factors that were associated with this change in the screening rate. And this is the major result from the study. I want to point your attention to the 3 lines in the figure, the blue line towards the bottom of the figure being rates in the United States, the yellow line in the middle being screening rates in California, and the gray line towards the top being screening rates in Los Angeles County. And again, want to reemphasize that this is just in community health centers or federally qualified health centers. And we really saw that although screening rates were increasing from 2014 to 2019, we had a drop in screening participation in 2020, right around the time of the pandemic. And there was some improvement after that in 2021. There was some recovery. In the state of California, where we reside, and in Los Angeles County, we actually, for the first time during the pandemic, saw colorectal cancer screening rates dipping below national screening rates in federally qualified health centers. We did have some recovery, but notably, clinics that serve a majority Black population had continued declines in screening participation right after the pandemic. The last study that abstract that I want to focus on that dealt with disparities looked at interventions to increase screening in under-resourced populations. So we've talked about how these disparities exist. We've talked about how they've worsened during COVID. What can we do to make disparities better? This is a systematic review. They were able to include over 500 studies and look at which qualified for their inclusion criteria, resulting in 33 studies that looked at interventions from 2003 to 2018. And what they concluded was that there are many different types of interventions that are effective for addressing low screening rates in underserved populations. We have effective unicomponent interventions. These are conventions that really have one main component, and we have effective multi-component interventions. So a lot of the work that we're doing now is trying to learn for different health systems and communities what we can do, whether it's mailed fit outreach, patient navigation, as was emphasized, telephone education, or more complex interventions like providing school stool kits through a programmatic approach to screening and patient reminder letters to improve screening participation in these settings. At DDW as well, there was a focus on high-risk colorectal cancer populations and individuals who are more likely to develop and unfortunately die from this disease. There are evolving recommendations specifically for colorectal cancer surveillance in individuals who have Lynch syndrome. And some of the guidelines actually now stratify the guidelines for surveillance based on the affected gene. What has previously been assumed is that individuals who have MLH1 or MSH2 Lynch syndrome may be able to start screening at age 20 to 25 with surveillance every 2 to 3 years or earlier if there's a family member that was affected earlier. But also there's been an assumption in some of these guidelines or an understanding that individuals who have the MSH6 or PMS2 Lynch syndrome subtypes might not to be screened or surveilled as aggressively given the lower risk phenotype of this disease. And this is something that has actually already been started to be practiced. This is an example of the British Society GI guidelines that actually do formally recommend this less aggressive approach. So this abstract that was presented at DDW tried to understand this new guidance in the context of the US population. They tried to characterize the clinical phenotype of Lynch syndrome patients of MSH6 or PMS2 in the US population. This was performed at one large academic institution, and they identified patients with Lynch syndrome specifically of these subtypes. They conducted a chart review looking at demographic information, cancer history, and colonoscopy outcomes for these patients. And in their analyses, they tried to compare characteristics of individuals with and without a personal history of colorectal cancer, as well as to compare colorectal cancer cases to non-colorectal cancer control cases. They had very interesting findings. They had 223 individuals that they were able to include in this study, and 18% had a personal history of colorectal cancer, so significant, 1 in 5. There were also 31% that had a first-degree relative with colorectal cancer, and over 40% were diagnosed before age 50. There were 12% of colorectal cancers that were diagnosed even before age 35, or again, where these new guidelines are suggesting we can start surveillance. I'll also note that in this study, the majority of young onset cancers occurred in patients without a family history of colorectal cancer, and also the personal history of one or more non-colorectal cancer Lynch-associated cancers, smoking, family history, were not associated with the risk. So really, when we look at data like this, we wonder if that new guidance to be less aggressive about this subgroup holds, particularly in our US population. And the conclusion here was that delaying or extending colonoscopic surveillance for these carriers could potentially result in colorectal cancer diagnoses that otherwise could have been prevented. So really, we're still trying to sort out how to best manage these individuals, and it may be that it is not safe to be more lenient in their screening and surveillance guidance. The last area that I want to focus on is artificial intelligence in colonoscopy, which was a very hot topic at DDW. And there are a couple abstracts here that I would like to highlight. We've already had a preview to this concept yesterday and today that all colonoscopies are not equal, and that colonoscopy, particularly for screening colonoscopy, quality matters. The ASGE and ACG have listed several quality indicators that we in particular should be paying attention to when we're performing our screening colonoscopy. And I've highlighted here in the red box the intra-procedural quality indicators that we particularly need to pay attention to really reduce the risk of post-colonoscopy colorectal cancers. So there are two abstracts that I'd quickly like to overview that looked at ways to improve colonoscopy quality. The first here was an abstract that looked to assess the impact of a computer-aided detection device from Medtronic on polyp detection in a large cohort of high-volume colonoscopists. Now, in this study, they used the GI Genius Medtronic CADI system in a single academic medical center. They have 12 rooms in this setting, and they had designated some rooms as having the GI Genius and some rooms as not having. And they let the colonoscopists rotate through the rooms over a 6-month period of time, and then looked at how the quality varied by individuals that were more likely to use the CADI detection devices versus not. Here are their main results, looking at 21 colonoscopies who performed over 4,000 colonoscopies. They found that screening and surveillance polypectomy rates were significantly higher in those rooms where we had the computer-aided detection device. They also found that the individuals, the colonoscopists that were majority users, meaning that they were more likely to use the devices than not, also had higher polypectomy rates in these rooms that had the devices than when they performed colonoscopies in the rooms that did not. The colonoscopists that were not using the devices frequently did not see a significant increase in polypectomy, even when they used the device. And the higher screening colonoscopy ADR and SDR was seen really only in these CAD-E majority users. So really emphasizing in this study that you can have improvement in detection of polyps during by using these devices, but really only when you use them consistently. So there is a learning curve, and there is something about consistency of using these devices. I'll quickly mention a second study that had similar findings related to early detection or computer device and AI detection. This was actually a randomized trial that aimed to evaluate the impact of a novel system called CAD-I to standard colonoscopy for adenoma detection. So similarly, in this study, they introduced a novel device for real-time colorectal polyp detection, and they looked at a primary outcome of the adenomas per colonoscopy, or the APC. They had several secondary outcomes as well. They were able to randomize over 1,000 patients to either getting a colonoscopy with a CAD-I or a conventional colonoscopy. And as you can see bolded here, the polypectomy rate was actually higher for the patients who had the AI detection system during the colonoscopy. And there was no difference in the withdrawal time, so it didn't lengthen the procedures. They were able to conclude from the study as well that there was no significant difference in the detection of adenomas, sessile serrated lesions, or polyps between the two groups. So again, this study is highlighting that novel AI detection systems can improve in the number of adenomas specifically per colonoscopy compared to conventional colonoscopy without increasing the withdrawal time. And these findings really support the use of these AI-assisted colonoscopy devices to improve colonoscopy quality, which is what we all are looking to achieve. So at this point, I'm going to pass the torch to Dr. Gupta, who is also going to continue on this voyage through the hot topics that we saw in this area